speaker.
All right, I think we're all eager to start. Thank you, Dave. And so it is now my pleasure to present Dr. Linda Resar from the Johns Hopkins University to speak on the origins and genetics of MPNs. Dr. Resar, you are up. Let me make sure. Oh, they are already controlling it. Okay, good.
Good morning. It's really an honor to be here among all my esteemed colleagues, and it's especially a privilege to be able to interact with our patients and to meet so many of you. And I've tried to gear my talk not only for the new people here who it's their first visit, but also to those of you who've been coming to this symposium for a long time and know a lot about the disease. Hopefully there will be a little bit for everyone, but thank you very much. So just to get started, we are going to talk about the genetics of MPN. And so in doing so, I would like to introduce you to two patients because you patients are our inspiration. It's why we do what we do. And I have a patient who was quite young. I've been following now for almost a couple of decades. And then another patient who's very dear to me. I've known her all my life. She's actually my mother. And they exemplify some very nice features of the disease and how our patients can do very well with appropriate management and lifestyle interventions. So we're going to talk about drivers. Many of you will know these already. What are the mutations that cause MPN? Why do we have them? How do we acquire them? And then what about in this age of social media, the influencers? Because you will learn that there are people with JAK mutations who don't yet have disease. There are people who have disease. How is it that some present as children that I see? I'm trained in pediatrics, so my clinic is young children, adolescents, and young adults with MPN. And how is it that other patients present at 80? So these relate in part to the influencers. So I'm going to start out with two patients. This was my very first MPN patient. I met him when he was 17. His parents had picked him up from college for the winter break and noticed that he was yellow. He got taken to his primary care doctor. They did a number of studies. He was interestingly noted to have low blood counts. He was actually anemic. He had a huge liver and spleen. The spleen was down into his pelvis. He had elevated liver tests to show, which typically mean that there's inflammation in the liver. So of course his primary doctors started to look for evidence of hepatitis, infections, drugs, others, all of that was negative. He then was referred to Hopkins where he got an attempted liver biopsy. The first biopsy was through a transjugular catheter, which means it's going through his venous system. That could not be performed because they encountered an obstruction. And this obstruction, of course, suggested that there was a clot in his hepatic vein, and some of you may know that this is also termed Budd-Chiari syndrome. It's actually something that we see much more common in younger patients than older patients. So ultimately, he got a biopsy that went right through the skin. It showed some fibrosis, and despite the fact that he was anemic, MPN was suspected. So he, like many of you here, had a number of different studies performed. He had a JAK mutational analysis performed, which was indeed positive. Back maybe 10, 15 years ago, we could actually do a measure of red cell mass, like how many red cells are they? We know out of CBC he was anemic, but his red cell mass was actually elevated. And sometimes when patients have a big liver and spleen, a lot of that blood cell mass can be in the liver and spleen. So this patient was anemic, but in fact, he was making too many red cells. And ultimately, he got a bone marrow biopsy that showed increased cellularity. I think many of you know when you have a myeloproliferative neoplasia, you can be making too many mature blood cells, and that can cause a problem. Sort of like if you think about beads in a tube, too many beads will clog up that tube, and that's one of the complications of our patients who have polycythemia vera. So Josh was managed initially with phlebotomy and, of course, anticoagulation therapy because of the thrombus. He initially did well. But unfortunately, like many of our young patients with Budd-Chiari, his liver failure progressed, and he even had some neurological signs. Our liver clears toxins from our body, and if they're not cleared, our cognitive function can be impaired. He ultimately underwent a transplantation from an unrelated donor and actually did beautifully. He initially was managed with phlebotomy. However, he developed iron deficiency, which is quite common in our patients. He also had some trouble in school focusing, and iron deficiency is associated with that. He continued on blood thinners and was also started on pegylated interferon, which initially caused some cytoreduction and was beneficial, but he developed some increasing liver function studies, which makes it very challenging in a patient with a liver transplant. Those studies are follow the graft, his acceptance of the transplanted liver. So he had to switch over to ruxolitinib, a JAK inhibitor. And now he's 15 years off therapy with a new liver and actually doing beautifully. So what about the genomics? In him, as in most of our patients with MPN, a mutant JAK gene is what's causing the myeloproliferative neoplasia. When he first presented, we were not able to do a panel of other genes that could be associated with his MPN. We call this sometimes a leukemia panel, a genomics panel. These are studies that are being done much more frequently now, and we're learning more about the variability in the underlying genome of our patients. So when we did this genomics study, he was found to have another variant, something in a gene called KMT2D. It's a gene that regulates how genes are expressed or silenced. He had a 30% of that allele burden. He also had some germline lesions. So I'll be talking a little bit more about this, but these are variants in our DNA sequence that are typically inherited from one parent, and they may influence the underlying JAK mutation. So in Josh, he had an ATM variant, and ATM is a tumor suppressor. It's a gene that makes a protein that tries to put a block on tumor development. Whether or not this played a role in his MPN, it's not clear. He also had another genomic variant in the MEF2B regulatory gene. This encodes a protein that also regulates how genes are expressed. And when we do these genomic studies, many of you may have had that. First, you look for the driver. Is it JAK? And you know, of course, there's 2 other mutations that are common drivers in MPN. And then we look at the whole genome. What else is going on, and how might this be impacting that individual's MPN? So we'll be talking about that a little bit later. Now, just to get back to Josh, he's doing great. He's got a new liver. His counts are well controlled on the ruxolitinib. He's finishing college. Of course, his school was interrupted with all those medical challenges, but he likes to scuba dive, and here is a picture of him. So now I'm going to tell you about our next patient, who, as I mentioned, is a young octogenarian. So when Lucy was 71 years of age, she had a transient episode of blurry vision. A CT showed really nothing to cause this, and a CBC was not obtained at that time. Notable in her past history was that she had been diagnosed with an ocular migraine, and she also had hypercholesterolemia, for which she was on Lipitor. She also had noted headaches over 20 or 30 years and occasional tingling in her hands. And she had a very remote history of smoking in her 20s for a few years. At age 78, a CBC was obtained, and there was a tiny bit of erythrocytosis. The red cell count was just above the normal limit. 2 years later, she developed profound shoulder and joint pain, and her doctors worked her up for underlying inflammation. Some of you may have had SED rates done or CRPs. These are measures of inflammation. They were very high. She was ultimately diagnosed with polymyalgia rheumatica, and she was treated with tapering steroids over about a year. All those symptoms resolved. However, in her blood counts, she developed an increasing platelet count. It was originally thought that the platelets were up because she had inflammation and PMR, but it became sustained even after the steroids was stopped and the inflammation had abated. So I think you're probably guessing what was done next. She had a JAK mutational analysis performed, which was positive. She was originally treated with phlebotomy and, just like Josh, developed iron deficiency. Ultimately, she was transitioned to Ropeg with excellent control of her counts. She's currently getting treatment just once a month. And as we talked about, her genetics test showed JAK mutation, and her what we call allele fraction was 21%. She also, when we looked at her whole genome, had a variant in a gene called Notch. Again, Notch influences how blood cells grow, and whether or not this had any impact on her disease is not yet clear. She just turned 87 years old. She has a Fitbit and walks at least 3 miles a day. She works in retail. She's active in book clubs and bridge. She actually tells me she always wins. She plays rummy cubes, and she feels great. And this is a picture of my mom with our dog. So these patients, I think, are beautiful examples of the spectrum. A young patient, a patient in their 80s, they're both doing well. And that's our goal for all of you. So we're going to talk about 3 things pretty much on each slide. So first off, driver mutations. Many of you have heard of JAK, CALR, MPL. These are acquired mutations within our blood stem cells that soup up the engine of our stem cells, sort of like a car. It's souped up. Too many blood cells are made, for example, in polycythemia vera, just like you heard in Josh, that caused his obstruction in the vein from his liver. In my mom, for instance, the headaches, the tingling of the hands, that was related to too many blood cells. These are stem cell disorders, so we're going to talk a little bit about stem cell biology, which is just fascinating. And then you all, I'm sure, from getting blood counts, know that we look at 3 types of blood counts. We look at platelets, we look at red cells, and we look at white cells. So what are the drivers? I personally drive a Prius. This is sort of like a normal stem cell. It's not, if I want to go fast, it's not going to happen. If I want to crank up, accelerate, I can. I get to work, no problem. But, I'm not going to be going 200 miles an hour down the JFX if I'm late for work. However, if you acquire a JAK mutation, your stem cells are a bit souped up. This car, if it wanted to accelerate like that, I think it could. It could drive 200 miles an hour if it wanted. The Prius, there's just no way. And if you really, really want a souped-up car, you could get a 2025 Corvette. And that's, let's say, a higher JAK allele burden. There's more JAK. The engine is more souped up. The stem cells are really cranking out the blood cells. So these are the drivers. And what exactly does that mean? So as I mentioned, our stem cells, they are dividing. And every time a cell divides, the entire genome has to be replicated. And there's a certain amount of error to that. If you type like me and you have to type an entire page, there's going to be some errors there. The same thing is true of replicating our genome. The proteins that do this have a certain fidelity. They're not perfect. They introduce mutations. And so these mutations that are acquired that soup up our engines and expand our stem cells are driver mutations for myeloproliferative neoplasias. And what they do is they crank up the growth signals in the cell. And I'm just showing you the biochemical pathway here. The pink dots represent cytokines. We all have growth factors that tell our stem cells to divide and start, like the car, to get to work. If you get a JAK mutation, it's more like a Corvette. They're really cranking and making cells and getting down those highways quite rapidly. And some of our patients, as you know, will progress further to myelofibrosis. Some people actually present with myelofibrosis, and some will progress to a leukemic transformation. And our hope as scientists and physicians is by investigating these disorders, we can understand what's causing them and then stop them. So we talked about the JAK mutation. It's present in most people with PV and about half of people with ET or myelofibrosis. Most often it's a mutation or a change in the sequence that gives rise to a new protein at exon 14. It's a region of the gene. There are also some mutations in another region which are less common. CALR is another mutation. It's most commonly associated with ET, or primary myelofibrosis, or secondary myelofibrosis. And there's two different flavors to the CALR mutations. One is it's missing a little bit of the sequence, and there's a less common insertion where it's gained some sequence. And then MPL is the least common, but it's most often associated with ET, or primary myelofibrosis, or myelofibrosis. So what do these mutations mean? Why are they souping up the engines of our stem cells? Well, normally our stem cells receive signals which tell them to divide and make blood. If you have a JAK mutation, again, it's like the Corvette. It's getting a little bit too much signal. It's a souped up engine. The other mutations also serve to soup up these receptors that are communicating with signals in our bone marrow to make blood, and they're getting too much signal. And this is just diagrams of these receptors receiving too much signal. So, as I mentioned, there are three primary driver genes. Most often it's a mutation in JAK, but we can have other mutations that crank up the engines. There's stem cell disorders. So they're telling our stem cells to produce more than ordinarily. They're going from the Prius to the Corvette. And there are three flavors, as you may know. Some patients present predominantly with elevations in platelets, and that actually was how my mom originally presented. Some people present with elevations in red cells, as Josh, and some people present with scarring of the bone marrow or myelofibrosis. Now we're just going to take a dive into the stem cells to sort of understand, well, what do these mutations do and why do they manifest with excess blood? So our blood is made in these remarkable stem cells called hematopoietic stem cells. It comes from Greek, meaning blood and creation. They generate blood, and these are really, truly remarkable stem cells. Everybody makes approximately 400,000 platelets every day, 400 billion platelets a day, 200 billion red cells a day, and 10 billion white cells a day. That's a really big job, right? So these stem cells have to be able to make blood. And I always tell my patients, I'd like you to go for about 100 years. I want your stem cells to be functioning for 100 years. So how do these stem cells manage to do that? They have remarkable features. That is, they have to be able to renew themselves, make identical daughter cells, self-renew. They also have to make blood, and you know a lot about that, and we've just talked about the different blood cells that our body needs. So they need to differentiate. The other incredibly important feature of a stem cell is they have to chill out. If all of our stem cells were making blood from day 0, we would run out. We would like them to last about 100 years. That's my goal for my patients. And some of you have had bone marrow aspirates to see what that looks like. This is where the stem cells live. They live in our bone marrow. And we also look at our blood smears. The upper left is a normal blood smear. On the right is a patient with ET. You can see this clump here. These are excess platelets. On the bottom, next slide, is somebody with PV. You can see the red cells are a little bit crowded. And here is a patient with myelofibrosis. So there is bone marrow scarring, and as a consequence, those souped up stem cells are no longer able to make as much blood. You can see the blood's a little less dense here, and there's some shapes that suggest the marrow might have some scarring, and they may become misshapen as they leave the bone marrow. And many of you have had bone marrow aspirates and biopsies. This tells us what things look like in the marrow. This is a normal one, and this is a patient with MPN. You can see it's a bit crowded, and you can see this megakaryocyte is large with lots of little micronuclei, which is also characteristic of myeloproliferative neoplasia. So these stem cells are amazing. They have to make a huge amount of blood. So what happens? How many are we born with? How do we keep our stem cells healthy? So in our bone marrow, there's quite a few cells, about 1 trillion. If you take a subset of that, 10 billion, they're CD34. That means they're stem and progenitors. Our stem cells, we're actually only born with about 100,000 stem cells. That's not a very large number. And at any one given time, mathematical modeling suggests about 1,000 of these cells are active in making blood. That's why, remember, stem cells have to chill out. So most of them are chilling out. About 1,000 of them are making blood. So why are some of them acquiring mutations? If we think about the numbers, it's pretty remarkable. 100,000 at birth. Every time a stem cell divides, it acquires typing errors. Like we talked about, we have 30,000 genes. We have to replicate the entire genome. So our stem cells are acquiring about 10 mutations a year, all of us. That's a huge number. About 1 out of 10 will actually be in a protein that's required to regulate the cell growth, such as JAK. So by the time we're adults, and this isn't old, this is 20 years old, we have 2 mutations in our hematopoietic stem cells that are affecting proteins that are needed. We have 200 mutations throughout the genome. Most of our genome is not encoding genes, it's regulatory regions and other areas of the sequence. So with 100,000 hematopoietic stem cells, we have 200,000 mutations. And by the time we're 70, that's 1 million. So it's remarkable that we make blood for as long as we do and as well as we do. And so what happens is, early in life, most of our stem cells are not mutated, but actually very interesting mathematical modeling of clonal evolution, which is how we term these mutations, how they expand and change, suggests that some of these are even occurring in utero, so that by the time we're early adults, we have stem cells that are unmutated and some that are mutated. And as we get older, the ones that are the corvettes, the really good engines, are expanding and taking over and enlarging compared to the unmutated stem cells, such that by the time we're older, we have a lot of mutant stem cells. Okay, so again, it's sort of like a car. If we were to take 100 Priuses and 100 Corvettes and we had to drive 1 million miles, I'm sure that towards the end of that, there'd be more Corvettes on the road. And again, this is just a diagram. Our stem cells are picking up a lot of mutations. JAK turns out to be one of the more common mutations that we pick up with age. And some of the mutations we pick up have absolutely no consequences. They don't make the stem cell souped up. They don't slow it down. So they don't expand. But the ones that do give the engine a fitness advantage, make the Prius more like a Corvette, those expand because they're making more blood. And this is just another diagram of common mutations that are picked up over time in all people. The other thing, Dr. Hasselbach, who we'll be hearing from next, did some beautiful studies in the normal population. And even if you take all people, including those not known to have myeloproliferative neoplasias or abnormal blood counts, there is an incidence of these mutations. And if you break it down by age, as you might expect, these mutations are more common in older folks. And even CALR mutations are present in the normal population. And as I alluded to earlier, there were mathematical modeling studies that suggested some of these mutations were actually occurring in utero. So isn't that remarkable? And I guess if you think about it, since our stem cells have to replicate in utero, in fact, they're replicating rapidly in utero, of course there will be some acquisition of mutations. So in retrospect, maybe it's not quite as surprising. And then we can actually use this mathematical modeling to look at patients and see when they developed their mutation and when they became symptomatic with disease. And the surprising thing, being a pediatrician, I thought, well, that makes sense. My patients all got their mutations in utero, and that's why I'm seeing them as young people. And my mom, she probably picked it up later. But in fact, when you look at the trajectories, that's really not the case. So here's a patient who became symptomatic at age 30. They had a JAK at birth. Here's a patient who became symptomatic in the 80s. They also had a JAK at birth. And you can see they're acquiring different mutations at different times of their life. And so we think about these mutations potentially as influencers. They either crank up the engine or maybe downgrade the engine. And that likely contributes to when patients become symptomatic. And so this mathematical modeling idea actually got a lot of flack when it was first proposed. But ultimately, there were patients who were identified at age 30 who had a CALR and myelofibrosis, and there were neonatal blood spots. You may know when newborns are born, they get blood drawn to screen for common diseases that could be prevented. And when they went back to the blood spots on these twins with myelofibrosis, they found that those mutations indeed were there at birth. And there was another patient as well documented with PV whose blood spot had that mutation at birth. So we know a little bit about drivers now. And we know that some patients have these mutations, but may not have manifestations of their disease for decades. We know that some patients present very early. So why is that? So in this era of social media, we're going to talk about the influencers. So what are the influencers of these MPN driver mutations? So there can be acquired influencers. These are, as we mentioned, our stem cells. Every time they divide, there's a chance that they're picking up a mutation, and there's a chance that this mutation may affect how that stem cell grows and divides. So an additional mutation can be an influencer. And indeed, about 50% of MPN patients will have additional mutations. And as we talked about with the car analogy, they can be upgrades or downgrades. We also talked about genomic screens. We get a lot of variants seen in our patients, and we don't know the function, because to know the function, you have to do experiments in cells and mice, and we have 30,000 genes. So this will be an issue for a long time. But patients have an underlying variation in their genes, which may affect how their other genes work and how these proteins influence the JAK mutation. So those germline influencers, acquired influencers, and then there are other influencers, like in the environment. Patients who have been exposed to smoking, radiation, chemotherapy, those could provoke additional mutations and add to the mix, the tapestry of mutations that influence the underlying driver. But there are also good things that can benefit patients and protect their genomes, like exercise, like a non-inflammatory diet. There can be inflammatory disorders. Many of our patients with MPN have an underlying inflammatory disorder. That was sort of a predecessor to my mom's MPN diagnosis. She had PMR, cardiovascular disease, but also anti-inflammatory lifestyles can impact the disease. So acquired influencers, again, these are just mutations within the stem cells that can either be engine upgrades or engine downgrades. And here's an interesting trajectory. It's a patient who had a DNM T3A mutation traced to birth, got a JAK mutation at about age 30, and did not present with MPN till the 70s. So you might imagine some of these mutations or this lifestyle were influencers that mitigated the development of an MPN, or at least the symptomatic presentation of MPN. We talked about germline influencers, and these are particularly interesting to me. So variations in the JAK gene, not surprisingly, can influence when that presents. Variation in inflammatory genes can influence that. And there are other genes. My lab, for instance, studies a gene called HMGA1. And we know that germline variants in this gene increase the risk for developing MPN. And these are just two studies that show that. They pile up little dots on the genes that influence. In our laboratory, we know if we decrease the amount of this gene in blood stem cells, we can prevent progression of MPN. Here's a mouse model with myelofibrosis, and the mice remain normal if they lose half of a copy of this gene. So we're actively investigating that to see how we can actually manipulate the gene or downstream products in patients. And this is another study showing that that gene goes up with transformation to leukemia. We talked about environmental influences, and I know Dr. Hasselbalch will be talking about that, but it's an exciting area because this is something that we all can change. We can modulate our diet, we can modulate our exercise, we can modulate our weight. There are some things, of course, we can't really change our genome very easily. So what I hope that I've imparted today is a little bit of knowledge about what are the underlying causes for myeloproliferative neoplasia, the drivers, the cars, the things that make our engine souped up, and why that causes MPN. They modulate these remarkable stem cells, and really everyone is acquiring mutations in their stem cells. And I always tell that to my patients because I think it can be kind of scary and isolating to hear I've got this mutation in a disease, but really, we all have mutations. Some of them manifest and others are silent. It's almost a normal process. If you weren't alive, your stem cells wouldn't divide and you wouldn't acquire mutations. So this is really just a biology of having stem cells and making blood and being alive. And we know from those various trajectory studies, some patients may have JAK as early as being born in utero and don't develop disease for decades and decades. Others will develop disease like Josh as a teenager or even younger. So there are influencers, and we talked about germline lesions, other mutations in other proteins that affect the function of that driver. We talked about environmental influencers, and we talked about exposures. And we also talked a little bit about how we might be able to modulate inflammation and potentially dampen the effects of a mutant gene. I heard a great discussion with one of our patients here who told me that they went on an exercise and diet intervention, and it really improved his health and undoubtedly improved his disease. So I think there's a lot of hope for all of you here in the room and for all of us to improve our stem cell function with aging. So as physicians and scientists, what we really would like to understand better is the molecular tapestry of MPN. So what we know a lot about the drivers, what about the influencers, and what influences can we influence? We'd like to learn more so that, of course, we can prevent clonal expansion and disease progression. And our ultimate goal would be to eliminate the abnormal clones. And for all of my patients, as I mentioned, I'd like your stem cells to function well for about 100 years. So I hope this was helpful, and I'd be very happy to entertain any questions.
Thank you, Dr. Resar, for this outstanding presentation. I'm sure that answered a lot of questions, generated a lot more questions, so please write them down for a Q&A session later. I agree with Dr. Resar. I think we all think maybe Corvettes are cool, but we want less of them in the street so that less accidents and injuries happen.